Assalamu alaikum everyone. So today I am back again with few cases. This is the various conditions which affects the fingers or hand. Okay, these are commonly asked as a 2 marks or 4 marks questions in your undergraduate examination, and sometimes you may get questions related to your postgraduate entrance. So we'll start with our first case today. We have, I think, 4 cases today. So this is first case is 20 years old male patient. He is a cricket player, and he had injury to the finger when he was trying to take the catch. What happened is when he was trying to take the catch, the ball suddenly, instead of directly coming into the hand, it hit the tip of the finger. After this, patient start having pain in the finger. There is a flexion deformity of the finger, and there is restriction of the extension of the distal phalanx. So this is the classical presentation of mallet finger. So what is mallet finger? Mallet finger is traumatic disruption of the extensor mechanism of the distal phalanx. Extensor mechanism of distal phalanx, distal to the distal interphalangeal joint. So when there is damage to the extensor mechanism, so finger will land up in flexion deformity. This flexion deformity is otherwise called as mallet finger. So this is the clinical, the mechanism of injury. If you see here, the player was trying to take the catch. Instead of the catcher coming directly into the hand, it hit the tip of the finger. So this is the mechanism of injury. Instead of ball coming like this directly, it hit the tip of the finger like this. So when there is an injury to the tip of the fingers, the extensor mechanism get disrupted. So before going understanding what exactly this is, we need to know what a little anatomy of the phalanx. So if you see, this is a middle phalanx. Middle phalanx, or I'll write it as MP. This is distal phalanx. Okay. So if I'm sorry, I don't know, it's a middle phalanx. This is distal phalanx. This is a distal DIP joint. It's otherwise called as DIP joint, distal interphalangeal joint. So if you see, this is the dorsal aspect. This is the volar aspect. Here you can see the nail. Okay, so on the dorsal side, we have the tendon which is responsible for extension. So it's called as extensor tendon. On the volar side, we have the tendon which causes flexion of the distal phalanx. This flexion is happening at distal interphalangeal joint. So this is the normal anatomy of the distal interphalangeal joint, and the muscles tendons responsible for flexion and extension. Am I clear? So what is the mechanism of injury? So mechanism of injury sometimes may have direct injury, sometimes may have indirect injury. What is the direct injury? At the point of distal interphalangeal joint, this point, there may be certain, direct laceration. It's happened is mostly work-related injury when carpenters or the butchers, they continuously use some sharp object to cut. Okay, so that is direct injury. Indirect injury is the traumatic impaction, sudden flexion forces over the extended distal interphalangeal joint. This is what we have studied before. We have came across the case. No, this is indirect type of injury where the ball hit the tip of the finger when it was in extended position. So we have two types. One is bony mallet finger when it affects the bone, tendon mallet finger when it's just cause separation of the tendon from the attachment. So in among bony mallet finger, we have two types: the fracture with subluxation of distal interphalangeal joint, without subluxation of interphalangeal joint. If you see here, this is type of non-bony, that is a tendon mallet finger, and here you can see the bony fragment attached here, so it's a bony type of mallet finger. So this is the classical presentation. The tip of the finger, that is distal interphalangeal joint, will attain attitude of flexion and there is lack of extension. So what will be the presentation? Injury. So this may be, depending on the type of injury, it may be a direct injury or indirect injury. swelling and deformity. The swelling in the distal phalanx and deformity at distal interphalangeal joint. So what is the attitude? The distal interphalangeal joint attained flexion attitude. As you see here, here is the flexion attitude and there is no extension possible. How will you diagnose? So yeah, the clinical diagnosis is a mallet finger when you examine clinically. But whether it is a bony mallet finger or it is affecting the tendon, unless you take the X-ray, you don't know. So when you take the X-ray, you need to look for two things. One is the fracture. One is if there is any subluxation of the joint or displacement of the distal phalanx at the distal interphalangeal joint. And when X-ray comes normal and you are having this deformity, then you need to diagnose the level of the cut in the tendon. It can be assessed by doing ultrasound. So there is a rule of ultrasound, a supportive rule of ultrasound in diagnosing patient who is having mallet finger. So once you have diagnosed, what is the treatment of mallet finger? So we can manage it conservatively. We may need to do surgery sometimes. So what is main, what is the thing used for management is splint. So we need to splint so that the distal fragment remains in extension. So these are various type of mallet finger splint. If you see this splint, it is blocking the flexion. Here also, if you see the distal interphalangeal joint is in extension with no flexion possible. So this is immobilization. We need to keep it for at least 6 weeks. How many days? 6 weeks. This we need to apply. So sometimes, no, if there is large displacement or the fracture fragments are not coming closer to each other, we need to go for close reduction under CM guidance. Or sometimes there is a tendon injury, we need to go for tendon repair. And if long-standing cases where patient is coming maybe after 3 months or 4 months, sometimes we can't do the resolvation, so we need to go for fusion of the distal interphalangeal joint. Here you can see how we apply the K-vads. So first is we need to stabilize the proximal fragment. So by passing the K-vad, we are blocking the displacement of the proximal fragment. So it won't go into extension. This we are blocking. Then we extend the distal part, distal fracture and try to bring it closer to it and fix it with the K-vad. So this is called as extension blocking K-vads. Extension, sorry, some problem in my extension blocking. Sorry for the this one blocking K-vad. Am I clear? Okay. If patient is having, presentation late with the deformity, so they develop, if neglected, swelling deformity or arthritis of the distal interphalangeal joint. The treatment for this one is we can't do the reconstruction procedure. We need to go for fusion of the distal interphalangeal joint. This is called as arthrodesis. So this is all about mallet finger. Hope I am clear for this one. Then we'll move on to the second case. Today's second case is a rugby player. While playing, he entangled his finger in the jersey of the fellow player. And after that, he started having pain in the distal phalanx. And he noticed that there is no flexion at the distal phalanx, at distal interphalangeal joint. If you see here, this is the mechanism of injury where the finger accidentally get entangled in the jersey of the fellow player. So jersey finger is traumatic flexor tendon injury. Remember, flexor tendon, it's a reverse of mallet finger caused by avulsion injury of the flexor digitorum profundus insertion at the base of the distal phalanx. So what is pathophysiology here? Flexor digitorum profundus is in maximum contraction, that is in flex position. And suddenly, if you are giving extension force, that is, you are creating extension, then the attachment will get avulsed. So if you see in the flex finger here, suddenly you are extending it. When you are extending here, the forces will go on either in the tendinous portion or either in the bonus portion, and they cause separation of this one. So either there will be a cut in the muscle or there will be avulsion of the attachment at the attachment of the tendon to the bone. So this is how it presents. So there is attitude, it is in extension at distal interphalangeal joint. and there is no flexion possible. Why there is no flexion possible? Because the flexor muscle, that is flexor digitorum profundus, which is causing flexion of distal interphalangeal joint, got damaged. Okay, what are the types? It may be a bony, as you see here. There is here, if you see, it's a bone separation, or it may be a tendon, that is discontinuity in tendon. So what is the presentation here? There is pain and tenderness over the volar digit, and the finger lies in slight extension because the flexion mechanism is damaged. So there is no flexion possible. So it will go naturally, over activity of extension, it will go into extension. And there is no active flexion is possible. Why there is no active flexion? Because the muscle responsible for active flexion, that is flexor digitorum profundus, it is already damaged. So when there is no muscle pull, there is no possibility of flexion. And sometimes if you do palpation, you can feel the flexor tendon along the course of the finger. If you see here, so how will you diagnose it? Again by X-ray. If you see here, there is avulsion of the flagship. This is middle phalanx, distal phalanx, interphalangeal joint. That is distal interphalangeal joint, and the attachment of distal phalangeal joint got avulsed. So patient is having this presentation, which we call it as jersey finger. So what is the treatment for jersey finger? So either here we always need to do surgery, because conservative treatment rarely successful here, because the tendon muscle pulling is high and there is lot of forces acting on the flexor aspect. So we can open and repair the tendon directly, or reinsertion of the tendon when it is avulsed, or open detection and fixation of the fracture. If patient is coming late, we need to go for two stage. So we need to harbor the tendon from the other side, and we need to reconstruct by doing grafting. And patient is coming very late with arthritis, then the only option left with that is orthodesis. What is orthodesis? Is the fusion of the joint in required position. It's a trans-surgical fusion. So if you hear this patient is having avulsion of the flexor attachment of the muscle, so it's a jersey finger. If you see here, what we have done, we have passed a caver, we have stabilized and fix it with the screws. So this is the post-operative X-ray. This is how you treat the patient who is having jersey finger. So we'll just compare mallet finger with jersey finger. So just for your review and easily remember. So this is mallet finger. Mallet finger. This is jersey finger. Okay. So before you need to understand the pathology behind it. So it is middle phalanx. This is distal phalanx. So this is dorsal aspect. If you see, this is the nail bed. Okay, am I clear? This is the nail bed. So this is DIP joint, distal interphalangeal joint. So these are extensors. This is flexion. Flexion, which flexor? Flexor digitorum profundus, because flexor digitorum superficialis will attach only here. This is flexor digitorum superficialis. So it's a pathology in flexor digitorum profundus. So it lands, if there is damage to the extensor, the finger will go into flexion. So we'll have flexion deformity here. If the flexor is damaged, then it will go into extension deformity. Am I clear? So this is how you need to differentiate mallet finger from jersey finger. Am I clear in explaining you this? Please let me know in suggestion box. Then we have a third case. Third case, the history is like 50-year-old female patient. She has history of diabetes. She has history of hypothyroidism. There is pain along the base of the finger. And whenever she is moving, there is click. Sometimes there is locking. And every time when the finger is getting locked, it is opening with the certain moment. It resembles how the trigger of the gun responds. Okay. So if you see here, the patient is having pain here, then triggering and flexion deformity. So whenever it is getting locked like this, when you are moving it back, it opens this as a trigger is it's a click of the trigger. So what is trigger finger? Trigger finger, if it affects the thumb, it is called as trigger thumb. is inhibition of the smooth tendon gliding. So tendon need to glide inside the pulleys at the level of A1 pulley due to stenosing tenosynovitis, that is constricting tenosynovitis. Why it is causing constriction here? Due to some pathology, either diabetic or a patient is hypothyroid and all, there is edema happening in the soft tissues. So this edema will change into fibrocartilaginous tissues, that is fibrocartilaginous metaplasia. It happens in the tendon, it can happen in pulleys. So this then followed by proliferation of the chondrocytes. So chondrocytes start producing unhealthy type of collagen, that is collagen 3. So resulting in stenosis of the canal. So once canal gets stenosed, then there is no smooth movement. So if you see cut section, how is the canal? This is the, if you see, this is bone and this is pulley. So and inside the pulley is the canal, here is the tendon. So tendon. So when there is a swelling this way or swelling that way, it causes constriction or narrowing of the canal. So the muscle which get affected in trigger finger is flexor digitorum profundus when it is affecting the fingers, flexor pollicis longus when it is affecting the thumb. And which pulley is involved? It is A1 pulley which is involved here. So if you see here, the pulley A1 pulley here is thickened and tendon is also inflamed and there is no smooth gliding. So it is getting locked every time. So what are the associated conditions? Diabetes, rheumatoid arthritis, gout, pseudo gout, and other autoimmune disorders and storage disorders also we find trigger finger. So what is the common symptoms? So it's a progressive disease. So once patients start having a pain, then it will end up in locking. Sometimes it may get locked permanently. So the pain is at the level of A1 pulley. A1 pulley is where, if you see here, this is your A1 pulley. A1 pulley is in metacarpal. This you need to remember, it is in metacarpal. So it's a metacarpophalangeal joint, MCP joint. Then comes your proximal phalanx, then middle phalanx, then it is distal phalanx. Middle phalanx, middle phalanx and distal phalanx. Okay. So clicking and catching will be there. Then finally finger becomes locked in flex position in proximal interphalangeal joint. May have sometimes the patient will have referred pain to the uh, proximal interphalangeal joint, dorsal aspect, and metacarpophalangeal joint. And sometimes this pain will be more than the initial pain what they have at the base of the finger. So kabhi patients are to nahi, if we ask if you are having pain here, they deny. They always start telling that they have pain here, they have pain here somewhere. And if you tell them that the pathology is here, they always look at you with a blank face. मैं बोल रहा हूँ यहाँ पे दर्द है, डॉक्टर साहब बोल रहे हैं इधर दर्द है. So this is a common clinical practice we get. So a patient will have pathology here, but due to the referred pain, they have more pain over the dorsal aspect. So if patient is complaining pain here, then also you need to suspect trigger finger and do proper clinical examination. So on examination, patient also have tenderness over the A1 pulley. And if you very keenly observe, there is a nodule at the flexor tendon region. So how will you diagnose? It's basically a clinical diagnosis. Ultrasound, it's not needed because it's a clinical diagnosis, but sometimes for insurance approvals and if patient is very Google patient, पूरा जैसे ऊपर the Google पे देख लेके आए, they want the confirmation of diagnosis, then you can do ultrasound. But ultrasound not always needed in this patient. Okay, how will you treat? So we need to give splint NSAIDs initially, rest basically. If there is no relief, you can try a shot of intralesional steroid injection. We can use either methylprednisolone or triamcinolone. And we should be very careful in giving injection because we should not give in tendon, not in tendon. We need to give in not in tendon. We need to give in around the tendon, not in the tendon. Sorry, we need to give in the the tunnel that is around the tendon, around the tendon, not in the tendon, but around the tendon. If you give inside the tendon, it may cause steroid-induced tendinopathy and sometimes result in rupture of the tendon. And if the patient is not responding, and you can go for surgical release, where we'll cut the roof, that is pulley. And if the patient is having severe tightness, then we can go for debridement of fascia digitorum profundus. So this generally happens in the patient who is having storage disorder. So the tendon will become very bulky. So you need to reduce the bulk of the tendon. Okay. So at this point, I just want to remember there is something called as congenital trigger thumb. What is congenital trigger thumb? Is they have, so due to some reason, they have the trigger for thumb deformity. Newborns, it present in newborns, and it's most of the time self-limiting. If it is what exactly happening here is there is narrowing of the A1 pulley of the thumb, so affecting which tendon? Flexor pollicis longus. So, and in this, you have a thickened nodular structure at A1 pulley. We call it as Notas nodule. Notas nodule sometimes asked as a PG question, PG bit for you. So, this the treatment for this one is we need to wait till 2 to 3 years. If it persisting, then we need to go for surgery. So, there is no rule of giving intralesional steroid in these patients. This is all about trigger finger. Now we have the fourth case and the last case for today. It's a 30-year-old postpartum 1 week female patient, obviously. She is complaining of pain along the bilateral thumb base. She is unable to take care of a newborn, and any thumb movement initiating excruciating pain along the thumb. And if you and she also complains that there is some swelling like thing around the radial styloid region, which is very tender. So if you see here, this is the point. She complains of pain and the swelling, and whenever the thumb is moving, she is having severe pain over this area. So this is a classical presentation of decurvence tenosynovitis, and it happens mostly after delivery. Okay. So what is decurvence tenosynovitis? Decurvence tenosynovitis is stenosing tenosynovial inflammation. That is, teno means tendon inflammation associated with synovial inflammation of the first dorsal compartment. ये dorsal compartment क्या बोला है? Dorsal compartment is when you see the radius and ulna at the wrist. This is dorsal aspect. This is volar aspect. So dorsal aspect is divided into cis compartment. So this is affecting the first compartment on the dorsal aspect. Okay. तो और ये और 5 कंपार्टमेंट, दिस इज आउट ऑफ बिजनेस फॉर दिस टॉपिक. कभी ये टॉपिक के करीब आए तो विल डिस्कस अबाउट ऑल द 6 कंपार्टमेंट. तो यहाँ पे यही रिमेम्बर करना है कि जो देयर इज अ पैथोलॉजी इन द फर्स्ट डॉर्सल कंपार्टमेंट. We call it a tenosynovial inflammation. We call it as decurvence tenosynovitis. तो हर जगह पे आप शुगर, हाइपोथायरॉइड ये नहीं ला सकते. इधर क्या होता है, देयर इज नो रिलेशन विद हाइपोथायरॉइडिज्म और डायबिटीज. So it's basically overuse. Some professions, golf and racket sports, sometimes post-traumatic and postpartum. Postpartum, after the delivery, many new mothers will have this complaint, and it will subside by itself. So, just NSAID and little rest will relieve the pain. So what is happening? So first compartment, there is inflammation. So what are the muscles in the first compartment? We have 2 muscles. One is we have 2 muscles. One is extensor pollicis brevis, sorry, and second is abductor pollicis longus. Abductor pollicis longus, extensor pollicis brevis. ये कैसा याद रखना बोलते हो? These are the 2 muscles. How I used to remember is extensor brevis. Extensor brevis is going in the marriage of Abdullah. So Abdullah contains AB, abductor, LL, longus. So abductor pollicis longus, extensor brevis. Okay. So what is happening is thickening and swelling of the extensor retinaculum, which causes narrowing and create tendon friction. Friction starts inflammation and resulting in the pain. This is how the patient developed decurvence tenosynovitis. So what is the presentation? It's a gradual onset pain on the radial side of the wrist. pain exacerbated by gripping and raising the objects with the wrist in the neutral position. There is tenderness along the first dorsal compartment. It is at the level of radial styloid. ये याद रखना जरूरी है. ये देखो आप यहाँ पे देखें तो radial styloid will come here, anatomical snub box come here. So yeah, the pain here is in radial styloid, not at the anatomical snub box. Anatomical snub box में pain है बोलते it is some scaphoid pathology, not decurvence. ये याद रखना. Sometimes in PG exam they will ask at the level of radial styloid or at the level of anatomical snub box. So there is a classical test to elicit, to confirm this one, that is called as Finkelstein test. Here what we do is, if you grasp the thumb and quickly abduct the hand in the ulnar position, there will be a provocation or a test. It's the pain will start after that. If you see the thumb is grasped and fist is made, and then when you are doing the ulnar deviation, the patient is having pain over this area. So how will you diagnose this one? Clinical diagnosis by clinical examination. If you are suspecting some something like radial styloid fracture, or patient has history of some trauma or anything, you can do some X-ray, and also even you can do ultrasound if you are suspecting any soft tissue pathology in the region. How will you treat it? Treatment is again first initial treatment, rest, splint, and acid. If patient is not responding to this, you need to give intralesional steroid. Again, here also you need to be very careful that you should not inject the injection inside the tendon. We need to give in the, not in the tendon, but if you need to give, you need to give in the sheath. Under the sheath, there will be some space where in between tendon and the sheath. We need to instill in that sheath. If patient is not responding, then we need to go for surgical release of the extensor retinaculum. So this is a definitive treatment. Okay. Here, so if you say there is one more condition which resembles decurvence, it is called as intersection syndrome. What is intersection syndrome? Patient will have inflammation at the crossing point of the first dorsal compartment. First dorsal compartment क्या है बोलते हैं Abdullah? Abductor pollicis longus and extensor pollicis brevis. And second dorsal compartment. Second dorsal compartment have two very simple muscles, that is ECRB and ECRL, extensor carpi radialis longus and brevis. So decurvence, you have pain along the radial styloid, whereas intersection syndrome, pain will be at the dorsal aspect of the wrist around the second compartment. This is the point where the patient have pain in intersection syndrome. Just to remember, I have written about the intersection syndrome. You no need to know much more than this one for intersection syndrome. Is that okay for you? Thank you for listening to my lecture. If you have any questions, you can message me in the inbox. If you have any suggestion also, you can message me in the inbox. Thank you.